You're listening to episode 38 of the Fed and Fearless podcast. On today's episode, I'm chatting with Dr. Lara Briden all about how to determine if you truly do have PCOS or if something else is going on. So stay tuned. Hi, I'm Laura Schoenfeld. I'm a registered dietitian and coach trained in functional medicine with a passion for helping women just like you ditch perfectionism and use food, fitness, and self-care to fuel your bigger God-given purpose. I believe that it's possible to achieve your biggest life-changing goals without the frustration, obsession, or negative self-talk that so many women subject themselves to every day. All you need are the right tools, the right mindset, and the faith to turn your dreams into reality. I'm here to guide you along the way. The truth is that you are so much more than a body, and I'm on a mission to help you change the way you think and act at a core beliefs level so you can transform your physical, mental, and spiritual health from the inside out. Are you ready to become fed and fearless in your pursuit of a healthy, meaningful life? Welcome to the Fed and Fearless podcast. Hey everybody, welcome back to the Fed and Fearless podcast. I'm Laura Schoenfeld. I'm your host as always, and I have a really extra special guest for you today. All my guests are amazing, but this is somebody who I really admire and just think the world of as far as her knowledge, as well as her compassion and her ability to turn complicated women's health information into easy to understand and easy to take practical action on types of information in not only her book and her blog, but everything that she does online. So this person is someone who I am always just so pleased to be able to talk to. And you guys will notice that in this conversation, we definitely could have gone on to a lot more content, and I'll have to have her back on the show, but she's somebody who has a wealth of knowledge about all stages of women's health and stages of life that can affect women's health and hormones. So I am excited to have with me here today, Dr. Lara Briden. Lara Briden is a naturopathic doctor and the period revolutionary. She's leading the change to better periods. Informed by a strong science background and more than 20 years with patients, Lara is a passionate communicator about women's health and alternatives to hormonal birth control. Her book, Period Repair Manual, is a manifesto of natural treatment for better hormones and better periods and provides practical solutions using nutrition, supplements, and natural hormones. Now in its second edition, the book has been an underground sensation and has worked to quietly change the lives of tens of thousands of women. And I would argue that it's not so much underground anymore, and it's not quietly changing lives. It's really profoundly affecting the face of women's health and even how practitioners like me address my clients and help them improve their hormonal health and help them understand their bodies better. So Dr. Lara's work is just so pivotal for so many women's understanding of women's hormones, how our hormones affect our health, how we can improve our hormones, and how we can resolve hormonal issues without relying on synthetic birth controls. So, like I said, super excited about this. It's a great interview. There's so much content that we cover. So I'm excited to share it with you. And without further ado, here is Dr. Lara Briden. All right, everybody, you are in for such a treat today because I have with me one of my favorite people in the health and wellness space in general, and someone who has always been an incredibly popular guest on not only my podcast, but pretty much every podcast that she goes on. So I know you're going to get a lot out of this, and I'm super excited for you to get to soak in some of her wisdom. So today we have Lara Briden with us on the show. How are you doing today, Lara?
Good. Thanks for having me, Laura. And just to let people know, you and I have met in person, which is just so nice in this online sphere. We got to spend a day together a couple of years ago. So
I think it was a couple days, honestly. Yeah. You very generously let me follow you around California for a few days. So it was awesome. So Lara's got a ton of expertise, and I should say Dr. Lara, because I always want to make sure that I'm appropriately talking about people's expertise. So Dr. Lara Briden, not just Lara. But so Dr. Briden has a ton of expertise on a variety of different topics when it comes to women's health and hormones. And so much so that we'll probably have her on very shortly after this to get her talking about all the different things that she could share with us. But today we're going to focus a little bit more on premenopausal women's health, specifically women with issues with irregular or missing periods. So before we get into the meat of the interview, I would just love to hear a quick little introduction in case anyone is not familiar with you. I'd love to hear about how you became one of the world's leading experts on women's hormone and menstrual health. And I am the 100%. I'm not just blowing smoke.
I shy away from terms like that. But yeah, yes. So I've been doing this a long time. I think that's part of it. So my background, I have a science degree and a biology degree, and then naturopathic doctor training from Canada, which is why I have a Canadian accent, even though I'm speaking to you from New Zealand. And then I just dove into full-time practice for 20 years and was treating, in the beginning, a lot of different people for a lot of different things. Over the years, it became very much treating women, especially a lot of young women, for the topics we're going to talk about today: losing their periods, having difficult periods in some way. And I just got a lot of hands-on experience. I think that's part of it, and which goes a long way. And then about 5 years ago, I put what I'd learned into my book, Period Repair Manual. And since then, that book has reached a lot of women, which has been great. And also it's allowed me to have lots of conversations with people around the world, like yourself, other experts, just getting feedback about the book and opening up that conversation more. So that's where I'm coming from. And I'm, as you can you'll be able to hear, I'm pretty passionate about this, about women's health and hormones. I'm a cheerleader for women's hormones. That's what I've said a few times, even though, just to put it in context, I'm 50, so right on the cusp of menopause. So I'm about to lose my own women's hormones, but I'm still extremely enthusiastic about them for younger women. And just it's interesting because you said we're going to talk about premenopausal women. One thing I realized, a lot of people, when they hear that, they think, oh, that means just before menopause. Like, no, actually premenopausal means all your reproductive years, which is 3 or 4 decades. We'll be speaking a lot about kind of women in their 20s and 30s, I think will be the topic mostly of today. But women in their 40s is a different topic again, I'm working on a new book about that.
Yeah, and I'm glad you pointed that out, because I always think of premenopausal as being my age, like I'm in my 30s, or, women that are younger than me, which is technically true, but I could see why somebody might think that a premenopausal is somebody going into menopause. So there's perimenopausal, which is kind of more of that, right, going into it. And then there's postmenopausal. And then that's the people that have already gone through it. So lots of different opportunities to talk about women's hormones at different stages, which I will say that's probably one of the reasons why, you and a few other people that I am in contact with, or just have friends in the industry that are people that I consider to be leading experts, because it's really not something that many people are talking about. And you have done such a great job of shining a light on not only the science piece, but also the practical and just application piece as well, with the book that you wrote and the blog that you continuously update and all of that. So I know that a lot of my clients really value your work, and I'm always sending articles that you've written to them because you do such a great job of explaining things super simply, which is why you are such a great resource for people. So, and one thing that you say a lot, and I think this was the topic of the little throw together not webinar. I always want to say webinar. I do so much virtually, but the seminar that we did in California back in 2018, Women Are Not Small Men. That was the name of the event, and you say it a lot, and I would love to hear from you. What do you mean when you say the phrase "women are not small men"?
Quite a fundamentally, in some ways, not in all ways, but somewhat different physiology than men. Although I like to flip that and say I like to, proclaim that the female physiology is the basic normal physiology, which arguably from a biology perspective it is, because actually, did you know that you probably know this, we're all in utero, we're all female until about week, I think it's 8 or something of gestation, when maleness kicks in. Maleness is like a little add-on that comes later. But femaleness is very much a normal physiology. But unfortunately, we're in this situation in all aspects of health, not just nutrition, but also in nutrition, where a lot of the discussion and the research, unfortunately, is about male bodies. And then these things are proclaimed about, what works for health. And a lot of it is actually what works for men. And a prime example is the low carb diet, which, is, I guess, arguably is going to work for many 40-something-year-old men out there. I might question it that I don't think it works for all of them, but it certainly works for a lot of them. But then when they say this is the diet that works, then I'm like, well, the diet that works for you may not be the diet that works for a 25-year-old woman. So it's just about reframing it and honoring our own bodies and what they need and taking that seriously. So, yeah.
Mm-hmm. Yeah, I feel like the lack of research on women in general, and then also the lack of research on women in the menstruating years, not on birth control, is just shocking to me. And it just means that we have to do so much more kind of our own digging and our own understanding of how women's bodies work. And unfortunately, what that means is a lot of it comes from trial and error and working with clients and seeing what's not working for women and figuring out why is that the case.
Absolutely. And another thing about this conversation, the thing I'm trying to reframe, because I think, unfortunately, the way it's so much is narrative, right? The story we tell ourselves about our body, the way we look at the body. We seem to have, collectively, this sort of idea that female hormones are somehow a liability to health. They're something to be controlled. You mentioned the birth control pill, kind of shut down because they're just annoying. That's sort of the idea we're given. And of course, it's so far from being true because both estrogen and progesterone are amazing for health. Like actually estrogen, both hormones are great, but estrogen is an amazing hormone. Not to overstate it, but it has so many benefits, both for men and women. Actually, men need their estrogen too. There's a small amount of estrogen just as much as but we are built around a larger amount of estrogen. That's not a liability. We can have times when estrogen is, causing a few problems, but that doesn't mean estrogen's bad.
Mm-hmm. Yeah. And I think that is something that just hormones in general tend to be misunderstood by not only just the general public, but even practitioners that are just looking at it from one angle, focusing on, too much estrogen or an imbalance of estrogen and progesterone and all of that. And yes, that can be a problem and cause symptoms, but the goal is not to eliminate the hormones or to totally take over hormone fluctuations using the pill and that kind of thing. So, so it's something that, whether you have low hormones and are trying to boost them, or if your hormones are out of balance or too high and you're trying to bring them down, the goal is not to just, take them out of the picture.
Shut it down, which unfortunately, as you mentioned the pill a couple of times, that's not to be too blunt, but that's what the pill does. Yeah. It shuts it all down.
There's so much that we could talk about. And I know that you have so much information about the birth control pill in your book and everything. And we might have to have you come on just to talk about the pill at some point.
Another day. Yeah.
But I think what we wanted to talk about today is something that really, even before we started recording, we were talking about how it is a little surprising how much confusion there is. Not only with the general public, but how many healthcare providers just have no idea about the difference between different types of hormonal profiles that can cause symptoms. So we were going to mostly focus on PCOS and hypothalamic amenorrhea today. Like I said, I'll definitely have Lara on again to talk about all the other things that we could talk about because we could probably talk for a whole day about this stuff. But I wanted to get into PCOS and hypothalamic amenorrhea because there's so much confusion about, what is PCOS? How does it differ from HA? How do you actually figure out what the root cause of an irregular or missing cycle is? So can you explain how the women listening and their healthcare providers, or if there are healthcare providers listening, how they can differentiate between hypothalamic amenorrhea and PCOS? And if you don't mind doing like a little bit of a definition of those two first, that would be helpful.
Perfect. Yes, I could do that. Just to back up one step, obviously this comes at the end of a full diagnosis. So if you're missing your period you do need your doctor's help for that. And she's going to look at some of the more obscure reasons for that, which there's a whole list of things which we won't go into today. But at the end of the day, two of the more common explanations or diagnoses given for a missing period or irregular periods are PCOS or hypothalamic amenorrhea. So PCOS is one, actually, let's say hypothalamic amenorrhea, that's the easier one. That's when in the most simplest terms, you lose your period from not eating enough. There's going to be other factors, but basically your brain has decided, looked at your situation, especially what calories are coming in, and decided, just a hard no on making a baby right now. This is not a good time. It's an adaptive good. It's not your body malfunctioning with hypothalamic amenorrhea. It's your brain making a very smart decision to not attempt to make a baby when there's not enough food or there's too much stress or other factors. So that's HA, which your listeners are probably quite familiar with. PCOS, unfortunately, it's called Polycystic Ovary Syndrome. The name itself is a problem because it's pretty much zero to do with cysts on the ovaries, which right there means it should be almost a back to the drawing board kind of conversation. They need to go back, rename it, reset the parameters, because it's just at the moment a big catch-all kind of umbrella term for anyone who doesn't fall into one of the other categories. So currently, my working definition for PCOS, which I personally think is the most useful one, is it's the situation of androgen excess male hormones, when all other causes of androgen excess have been ruled out. That's essentially functionally what it is. So there are other reasons to have excess male hormones causing facial hair and severe acne. So the doctor's job is to rule those out. It's something called adrenal hyperplasia, which is actually pretty common. The doctor has to rule that out. So then you're left with this situation where you've got a couple things going on. The high androgens have to be there by definition, although there's some set of criteria that don't make that by definition, but I think it should be by definition. There have to be some signs of high male hormones, whether measurable on blood tests, which they not always are, or facial hair, or like a more severe acne, especially jawline acne. And then as part of that, there could also be ovulatory dysfunction where you're not ovulating. So either not having periods or having what are called anovulatory period cycles, anovulatory bleeds, which means it's more like a random breakthrough bleeding. You're not ovulating. So you're not having a menstrual cycle, or at least not every time. And this is about literacy, right? So this is going back to what you said earlier, Laura, about how just so many basic things are not kind of understood by, not just by women, but like by their doctors. Like if we could all from the beginning speak about the importance of ovulation, then when someone's in a state of having anovulatory bleeds, which is pretty easy to figure out, then we could talk about it that way. It's like, okay, the problem is you're making estrogen, so, bleeding sometimes, but you're not ovulating, so you're not making progesterone. That's a part. That's a part. The anovulatory bleeding is more common with PCOS, although milder versions on the kind of sliding scale of HA, you could also usually just lose your period, but you could be in a time of having longer cycles and ovulatory bleeds as well. Would you agree with that with HA? That's kind of yeah.
Yeah. I mean, I look at anovulatory cycles as being, like you said, it's just you're having a bleed, but there's no ovulation happening. And the same things that can drive hypothalamic amenorrhea can drive an anovulatory cycle. So I like that your definition of PCOS is really looking at the high hormones that are part of PCOS that are not really seen in HA. So, and I say not really, because sometimes you can, and I know you know this, and I know you'll explain this in more detail, but you can have PCOS type symptoms and HA happening at the same time. It's not an either or situation.
Exactly. A good example, it's worth mentioning because it's a common one, is post-pill acne. So if you've been on a pill like Yasmin, the drospirenone pills are the main ones. Depending what country you're in, there's another drug they use called Cipterone, which is quite a strong androgen suppressing drug. So when many women come off that, they can get some rebound acne or skin breakouts. It doesn't mean, and unfortunately under the current diagnostic criteria for PCOS, which should be back to the drawing board, but under current diagnostic conditions or like criteria, if you get a bit of acne and are missing your period, you almost by definition qualify for PCOS, which sometimes that's completely wrong because sometimes it actually is the main driver is undereating. The situation would be coming off the pill, getting a bit of post-pill acne, but also at the same time undereating, so not getting your period for that reason. And one thing to keep in mind is that as soon as you can get ovulation to kick in, so ovulation is just so wonderful and so important and so central. As soon as you can start to ovulate and make higher levels of estrogen and progesterone, though both of those hormones have a natural anti-androgen effect. So you can start to get, help for the temporary androgen symptoms just by ovulating. So, yeah.
Mm-hmm. So it's interesting because I work with a lot of women that are not getting their periods and they struggle to get a good diagnosis, or they've been told they probably have PCOS because maybe they got an ultrasound and they had some cysts on their ovaries and they're not getting their period, which, as you know, with the current diagnostic criteria, that's all you need to get a PCOS diagnosis. If somebody has been diagnosed with PCOS, but kind of sees themselves in that HA type of behavior pattern where maybe they're really active, or they maybe don't eat enough, or they have a history of an eating disorder, or they just have a lot of confusion around food and maybe are like, stuck on that low carb train or anything like that. What can they do to figure out, do they have HA or do they have PCOS, or do they kind of have that like frustrating combination of a little bit of PCOS, but also HA, which is really the root issue?
HA always comes first. HA is always the thing to treat first. So if you do even have someone where you're like, okay, maybe you do underneath all this have a little bit of tendency to higher androgens genetically or something, you still treat the HA first. So if there's any evidence of undereating, that's treated first. I guess that's the way I would begin. And fortunately, I think it's pretty easy at the end of the day to pick that up. Like it's not rocket science to determine that undereating is the driving cause. We'll talk now about some of the lab parameters for that, and also clinical history. Obviously, I'm just asking someone what they're eating, which apparently doesn't always happen in doctor's appointments. Not just slam doctors, but
you honestly, I was kind of laughing because I'm like, I honestly am shocked sometimes how often that's not even a part of the equation for even. Like I've worked with student athletes that were seeing, a nutritionist on their team, and the nutritionist didn't even look to see what their calorie intake was or what their energy output might be. So it's, again, you and I are like, how is this not happening all the time? Like, how is this not part of the equation? But it's not even near as often as it should be. So for sure, if anyone's under eating, and I'm so glad you said that HA should really be ruled out first, and the approach should be like whatever you would do to heal HA needs to be happening before the PCOS is necessarily dealt with.
Absolutely. If in doubt, treat HA first. That's the general rule. And just before we dive into how to differentiate, we have to talk about the ultrasound because it is a big mess. I would probably put a swear word there, but it's just a big mess.
Well, and I was going to ask you about ovarian cysts and what it even means if a woman has them. So let's jump into that really quick, because like we said, there are women out there that have gotten diagnosed with PCOS because of ovarian cysts, and that's almost it. And I think that's a huge issue. Okay.
So the ultrasound, I'll start with a bold statement and then I'll qualify it. So, and this bold statement partly comes from this, Geraldine Pryor, who's a reproductive endocrinologist who helped me with period repair manual. She really knows her stuff. Not to overstate it, but she's a scientist. She's been doing this she's also a cheerleader for ovulation. She's been doing this for decades. She said to me during the writing of my book, there is almost no reason to do an ultrasound as part of the workup for PCOS. By almost, she means there's no reason to look at the ovaries on ultrasound as part of the diagnostic process for PCOS. The only reason to maybe do an ultrasound is to look for what's called a thickened uterine lining that can happen after years of anovulatory cycles, especially with severe PCOS. You can get something happening with the uterine lining, which is not good. So, that's why she's like, so ultrasound the pelvic ultrasound has a place for lots of things. It can see lots of interesting things. in the pelvis with the uterus and the ovaries, but polycystic ovaries are not one of the things that it has any business even looking at, because it doesn't mean anything. They're just eggs or follicles, which are normal for the ovaries. So younger women have a lot more follicles or eggs, which should be obvious, but needs to be stated. When you're younger, you have more follicles. When you're older, you have a lot fewer. So this is known. This is a thing. So this is why even the most conservative criteria now say, or even the most kind of mainstream criteria for PCOS say, any woman under 20, the ultrasound should not even be done. Like in terms of the polycystic finding means zero. We're all in agreement for any woman that young. I would say that's even true for any woman in her, 20, because really you can show these high number of follicles at any time, almost in any situation, like with PCOS, with hypothalamic amenorrhea, with a just normal situation. It's basically just really, if you want to think about it, all they're saying with that polycystic finding is that cycle, ovulation did not occur in that time that we're like in that snapshot of moment that we're looking. There's no ovulation happening. So there's no dominant follicle in the ovary at that time. And if your listeners know, a dominant follicle is just the huge egg that it really looks more like a cyst than the normal. Like it grows quite big when the egg is going to ovulate, and then it makes a corpus luteum. So the polycystic finding just means that that's not happening that month, but it doesn't mean it never happens. It might just be, because sometimes we have cycles, like any of us could just have a month where we don't ovulate. You don't want to read too much into that. So a lot of experts, not just me, are calling for the ultrasound, the polycystic ovary finding to be dumped, really, because it's just not helpful. Now, in answer to your question about ovarian cysts, that's a separate topic, right? So like a cyst in the true sense would be an abnormally large structure that is either an enlarged follicle, kind of dominant follicle, or an enlarged corpus luteum, or you can also have like cysts that are actually not even follicle material, but are endometriosis, or there's something called a dermoid cyst, which is a completely separate issue, right? Like, so certainly ovarian cysts exist, and they can cause pain, and they can sometimes require surgery. That's nothing to do with PCOS.
And it's interesting because, people, when they diagnose using a ultrasound, they say polycystic. It makes sense that somebody would think, there must be cysts on my ovaries. I know. But it's really just the follicles that are supposed to be there for the... Yeah. And not that if you don't have them, that means somehow you're abnormal, but it sounds like it's very, very common to have noticeable follicles. You'll always see follicles with the ultrasound.
So you always see some number of follicles with the ultrasound. This is just a numbers thing, right? So they decide, and actually there's more to the story too. So back when that criteria was sort of invented, I guess, or come up with, ultrasounds weren't as sensitive back then. So part of the problem now is with these like uber sensitive technology, suddenly it's like, whoa, we can see like so many follicles. And somehow, and so that's why they keep putting up, it's like, oh, it used to be more than 12 follicles. Now it's like more than 25 is a problem, because they're just zooming in on the ovary. There's always going to be follicles there, unless even after menopause, I think you might see a couple, as we get older, there are fewer. So seeing the word cyst does not apply to follicle. Technically, they're cysts, I guess, if they're fluid-filled little structures, but they're normal. And conversely, like just to put it in context, so if you're in your 20s, you're young, you have more follicles. High likelihood you're going to be told you have polycystic ovaries, even if you don't have anything to do with PCOS. Conversely, women in their 40s can be in a full-blown situation of androgen excess and insulin resistance. Like let's say really like absolutely full-blown PCOS in a way, because anovulatory, insulin resistance, high androgens, the whole picture and have normal looking ovaries because they're older and so have fewer follicles, right? So it works both ways. You can overdiagnose with ultrasound and you can underdiagnose with that polycystic finding. So with my patients, when they tell me, oh, this is my polycystic finding on ultrasound, I say, I don't care. I look at their ultrasound, like to see if there's anything else there, but I'm like, that polycystic finding, it's not of interest to me.
Well, I think that's really important to, make that clear to the listeners, that if you get an ultrasound done. And we're not saying ultrasounds are bad, right? Like there's reasons that an ultrasound could be beneficial. It can find, cancer, that kind of thing. So you wouldn't want to avoid getting an ultrasound if it's recommended. But knowing that getting an ultrasound and your doctor saying, well, you have polycystic ovaries, so the reason you're not getting your menstrual cycle is because you have PCOS, that is not
valid.
Accurate.
That's not valid. Mm-hmm. Good point. I'm not saying don't have your ultrasound, because the doctor, we don't know what.
I knew you weren't saying that, but I always like to make things very, very clear just in case, because we don't want people being afraid to get an ultrasound for any reason. No.
It's a good technology and it can pick up lots of things, but polycystic ovaries are not one of them.
Which is and again, it comes back to this issue that PCOS is just really misnamed,
I guess. Just a big mess. Yeah.
So, but until it changes, because I don't know when that's going to happen, I feel like things in the women's health world tend to move kind of slowly. So let's just operate under the assumption that it'll be called PCOS for a while. So we know that cysts on the ovaries can't tell you that you have PCOS. What kind of lab tests do you feel like are really valuable for women to ask their doctors for? Or again, we might be having a decent number of healthcare providers listening. Like if you're a dietitian and you want to suggest labs, obviously we don't order labs as dietitians, but we can suggest them to get asked for by their doctors. But what labs would you say are actually relevant to somebody who thinks they might have PCOS, but isn't totally sure?
Okay. Easy. So let's do that. So in the first, we'll kind of do it in chunks. So the first chunk is a bit more in the doctor's realm of just ruling out all other things, right? So they need to rule out adrenal hyperplasia, prolactin, thyroid. So that should have happened. Usually, hopefully that will happen. Then if you're like, okay, those things have been ruled out. So now we're kind of more in the territory of, is this PCOS or HA? Then, testing androgens, like testing testosterone and its companion called SHBG, or sex hormone binding globulin, is quite helpful. I think can be, and certainly that with true PCOS, that can come up high. So you can have high testosterone coming up on blood tests. That's not that unusual. You can have normal testosterone on blood tests and still, even by my criteria, fit under a PCOS diagnosis, unfortunately, but it's not absolutely, it's an indicator, it's part of the picture. So it's not diagnostic. Yeah. Having a normal testosterone doesn't rule out the problem, but definitely testosterone SHBG is worth doing. Then for reasons that we'll probably get into, I think it is worth testing insulin and determining, not just assuming you have insulin resistance because someone saw polycystic ovaries on ultrasound. Like insulin resistance is not that mysterious. You can test for it. And it's reversible. So you might have it one time and 6 months later not have it anymore. So having been told you had insulin resistance 12 months ago doesn't mean you have it now, especially if you've been dieting, in which case you could have actually swung into more. Maybe you did have insulin resistance at one point, but if you're 3 years on, you could now be under eating, for example, which is almost, I'd say almost the opposite of insulin resistance. It's not quite that simple, but under eating usually comes back with a low insulin picture. And I don't know, this is not, I'm just going by my own patients, but I sometimes do say with patients, okay, your insulin's too low. Like that's part of the picture of undereating for me, is this super low fasting insulin. And just to put in context, insulin is a hormone different than glucose or sugar, which is sugar in the blood. We're talking about testing the hormone. And as per our conversation before about estrogen being both good and bad, insulin is a good hormone. We were talking about this before we came on air. It has many benefits. In fact, you will love this. I just saw this yesterday. Insulin, I'd almost have to glance at my Twitter. It's a co-gonadotropin. That was the phrase. So gonadotropin is like signaling from the brain to the ovaries to ovulate. Insulin signals is part of that signaling mechanism, which is super interesting. I'll send you the paper. So the ovaries respond to insulin. The whole what we call HPO axis, the communication between the brain and the ovaries, responds to insulin, which is actually why having too low insulin arguably just kind of shuts that down. Like we need some amount of insulin to say to the brain and the ovaries to go ahead and do this, ovulate. So
yeah. The way that I look at it is that you need healthy insulin signaling for ovulation, and healthy insulin signaling is not really high insulin, and it's also not really low insulin. And so I'm glad you mentioned that people can be told that, hey, you have cystic or polycystic ovaries, and I'm doing air quotes. You have polycystic ovaries, so you have PCOS, which must mean you're insulin resistant, and you therefore should go on a low carb diet. And it's exactly. And it's one of these things where honestly, it happens so often that it's shocking to me, but it's important that we talk about this because low insulin is just as much of a problem for people as high insulin is.
So insulin has other benefits. So it signals ovaries, ovarian function. It is anabolic. It helps with muscle building. It's important for the immune function. So there's a long list of things, which it's just, I had this one page like this, these things stick in my mind, conversations with patients, and then some of them end up in my books. But like, I said, okay, we've got to get your insulin down. And she's like, oh, do you mean to zero? I'm like, no, I definitely do not mean to zero. No, that would be bad. So yes.
Yeah. So I think insulin for sure is one of those ones that can really help distinguish between HA and true PCOS for sure. Is there anything else that you like to see tested when you're trying to distinguish?
I do an LH-FSH ratio. So let's talk about that. I mean, I'm pretty confident about it. I've had obviously, some clinicians maybe don't agree as much. It's like many things in health. It's not absolute, but it can be useful in terms of the big picture. So LH and FSH are the two hormones coming from the pituitary to the ovaries. And in very simple terms, which when in the situation of undereating, or HA, LH is relatively low compared to FSH, or either the low or the same. Both hormones go up with age. So that's why we can't give an absolute number, because if you're 35, you're going to have higher LH and FSH numbers than if you're 20. That's just normal. So we do have to think about it as a ratio. In general, in many cases with PCOS, LH is high compared to FSH. Now it is this what they call pulsatility from the hypothalamus and the pituitary. So there's a sweet spot, right? So if it's pulsing too slowly, then low LH, and you won't get enough stimulation for the ovaries. If it's pulsing too quickly and high LH, often associated with insulin resistance, then you won't be able to successfully stimulate the ovaries because it's past the threshold of what's actually going to work as an ovulation switch, if that kind of makes sense.
I just want to make sure people know. So LH is luteinizing hormone, FSH is follicle stimulating hormone, and the pituitary gland is in the brain. So the brain is communicating with the ovaries and sending LH and FSH at different times of the cycle, pulsing it differently. And they work together to help not only mature a follicle for ovulation, but also to create that progesterone bump after the ovulation is done.
Exactly. Perfect. Fill that in. And also men have LH and FSH too, right? Just to put it in context. That helps with their sperm, that communicates with their testes. Yeah. So they've got that going on as well, but ours is different. This goes back to the women are not small men. Men do not have this. I mean, their hormones are affected by diet as well, but like they don't have this on and off switch like we have for ovulation. They don't have an on and off switch for their testosterone or their sperm production. They can maybe, if they're really undereating, can start to get lower testosterone, but it doesn't turn it off the way it does for us, which is, a lot of the men, even like I don't want to, slam anyone, but like even some really smart guys that I've talked to just have a blind spot. They don't know that women have this on-off switch that is very different from them. So there's that. One thing to say about when you're testing LH, FSH, this is actually quite important. You need to be literate as to where you were in your cycle when you're testing those. If you're cycling at all, so if you have 0 periods at all, nothing happening at all, obviously you have to just do a random day with that test. But you then have to be cognizant of that you don't then end up getting your period pretty much exactly 2 weeks later. Because what would that be? That would be if someone happened to see a really high LH, but then you got your period 2 weeks later, that was ovulation. LH spikes up really high just before ovulation. That's normal. So don't make the mistake of looking at that and thinking that's a confirmation of PCOS, because it's not. So any female hormone, you have to know where you were in your ovulatory cycle to understand what that means. Likewise, another good example would be getting a really low progesterone or almost zero progesterone, even if it's on day 21, but if it happened to be before ovulation in that cycle, it doesn't mean anything. It doesn't mean that you aren't making progesterone. It doesn't mean that you have estrogen dominance or anything like that. Like, you really have to, it's not just the number of what day you are in your cycle, it's where you were relative to ovulation, because ovulation is the main event. So if you are cycling, then the best day to test LH and FSH to get kind of as standardized as you can is day 2 or 3 of your cycle. That's when they're probably most indicative of this ratio problem.
And for people's just understanding, that would be if you're having a menstrual cycle, which I guess if you're not, you wouldn't even know what day 2 or 3 is, but you would probably be on your period that day.
Yes. So it's like, so day 1 is day 0 or 1 is the first day of your bleed. Not your spotting, not the spotting that came before, but the actual flow if you were tracking temperatures after your temperature goes down. That's quite a useful way to know what is day 1. It's after your luteal phase temperatures.
Mm-hmm. Yeah. And I mean, most people, obviously, if they're having a normal menstrual cycle, would be bleeding by day 2 or 3. If they're having a super light one, then maybe they wouldn't be, but if you're normally cycling, you'd be having it that day. So, which is interesting, because I know that the better time to test some of the sex hormones like progesterone, estrogen, is really that just after ovulation time period. So if you're going to be testing those things, sounds like you need to test at 2 different times of the cycle.
You do. That would be very common, that I'd say to a patient, here's your request form for blood tests for day 2 or 3. And then here's your one for a week after ovulation. So for progesterone. Which
I don't think most doctors are doing that, unfortunately. Usually that's just kind of a random, throw a dart at it and see where it's at and then make a decision from there. So I'm glad that you're mentioning this, because even just getting these tests in general can sometimes be like pulling teeth if you have to ask your doctor for it. And then to say, and can I have like 1 day for this and then the next day for that? It's like you might have to do a lot of education for your own doctor. Cool. Are there any other tests that you like to see done to help rule out or help to diagnose PCOS versus, I really feel like, just to kind of throw in my own 2 cents here.
Yeah, please.
My perspective, having worked with, I think we've had over 100 people in my Get Your Period Back program, and I've been working with clients for, I think this is year 7 now. I'm all about just like, let's go and do the lifestyle changes first and look at what you're eating, look at how you're exercising, look at your symptoms, look at how this is presenting. Let's make some changes first before going and getting all the complex lab testing done and everything, because not that I'm against lab testing, but my feeling is if to be accurate, it's going to require this level of precision, I would rather take care of the foundation first. And then if things don't resolve, then you can get in there with that more advanced testing and figure out, is there something else going on?
I agree. I'm more in the camp of less testing. I don't do a lot. Those tests that we've just talked about, testosterone, SHBG, insulin, LH, FSH, those are my core ones. Also, I mentioned a couple times, but just again, like ruling out prolactin and thyroid and other things. The other thing that's worth probably mentioning from a clinical perspective, like looking at symptoms, in general, HA is quite a low estrogen state. So there's not going to be, for example, potentially a lot of vaginal secretions or not very much that happening, not very much, breast swelling or anything, like just really, really flat in terms of hormone symptoms. Whereas with PCOS, they're kind of women are sort of running more at a higher estrogen level. So they might be actually seeing what looks like fertile mucus on and off, but it's not, they're not actually ovulating, but they're getting that sign of high estrogen. They're getting more breast swelling sometimes. So even with my patients, especially with my HA patients, because as you know, it can take 6 months or more to get your period back, even once you start eating. Like, it's not instant, and there are reasons for that. But it's like, it takes time. You have to commit to it. But sometimes, not uncommon, I'd say, I'll ask about that. It's like, have you noticed your breasts feel different, or you're seeing more, stuff in your underwear? You're kind of getting, hormones are kind of kicking in. Would you agree with that? Yeah.
Yeah, definitely. I think looking at the cervical fluid, cervical mucus changes, and then noticing even like mood swings and things that you would normally be seeing around the menstrual cycle if somebody has HA. Like somebody recently in my program mentioned that she felt like she was crying a lot more than she was before. And she was like, and she was like, I don't know if that's good, but I also feel like a lot of my HA clients tend to be a little bit emotionally flat too. So it is stuff that maybe doesn't feel like exciting, like, oh yeah, I'm crying and my boobs hurt. Like nobody necessarily wants that as a side effect, but those can be really good signs that somebody is recovering normal hormone functioning. I think it's a lot of times because they haven't started ovulating yet, but the estrogen's coming back online a little sooner. So they start to get that transient estrogen dominance type of effect. But it's part of the process for a lot of people.
Well, just to clear, I have to, you
don't like that estrogen dominance.
I don't like that term. Well, for one thing, for me, it implies that estrogen's bad, which I straight away reject that. But we make estrogen first, then progesterone, and progesterone only for a short, brief, blessed, couple of weeks. But like estrogen it's there. It's going to be there during recovery. It's going to kick in first. And if you have and it's there first in the cycle. And if you have a longer menstrual cycle, a longer follicular phase, it's there. That whole 3 weeks, it could be of normal estrogen, but not progesterone. That's technically estrogen dominance, but it's okay. So so estrogen kicking in, estrogen does affect emotions. I kind of like it. I think it makes us a bit, I don't know, just me going up on a tangent, but it makes us a bit more empathetic and maybe a bit more, I don't know. I hate to say a bit more spiritual. That sounds bad, but I feel like, estrogen, it's that intuitive. Yeah. Anyway, it's definitely affects the brain. And I'd say,
oh yeah, for sure. Estrogen is a good thing. I know that, again, it's this coming back online of the estrogen that sometimes just feels weird for people or has a little bit of that initial effect of strange symptoms, but down the road, especially as it's balanced with progesterone, it needs to be there. So as far as PCOS goes, because I think this conversation will be super helpful for even just the women in my Get Your Period Back program, because a lot of times they're asking about this, they get misinformation from their doctors. And there's just so much confusion. And like we said before, you can have both HA and PCOS. I know for me personally, I tend towards PCOS type of hormones. Like I tend to have a little higher androgens. I tend to have higher estrogen. I think that's in my genes to just have that tendency. But I don't know if I can say I've been diagnosed with PCOS or that I have it, but it is something that I think can be more of like an expression than an actual, like once you have PCOS, it's not that has to be the way that it always is.
It's how you're calibrated. That's kind of how I think about it. Some women are calibrated up, like they just make more hormones. It's good way you described it. I think it's probably, if you want to give it its due, give it credit, you probably had ancestors who are like just really good at making babies, especially under low food supply. And so that's like a superpower, really. Like that's not a bad thing. It's all that mismatch, it's kind of the matching with environment. So under a certain way of, a certain environment, or then that dialing up of hormones can tip over into causing symptoms, but you can reverse out of that. You can always reverse out of PCOS. It's reversible. So that's the symptom picture. Maybe not the genetic tendency, but the symptom picture is.
Yeah. And that's so important to say too, because whether it's HA or PCOS, I feel like women get these diagnoses and they basically feel like that's their identity now, or that's just what they have to deal with. And both of those conditions are highly reversible. And that doesn't mean that you are 100% like perfect hormones all the time. Like I said, I know for me personally, I do tend towards that higher androgen type of thing. And if I can keep my stress levels low and keep myself well fed and sleeping and all that, it usually doesn't really show up as anything. But just remembering that this isn't like, a life sentence of now this is the way it's going to be. So I'm so glad you said that, because I do think most women, the way that their doctors talk to them about these conditions, it's kind of like, now this is what you have and you'll always be this way. And not all doctors are like this, but a lot of doctors are like, the only fix for this is birth control, and you'll be on birth control until you want to have babies, and then you'll come off it. You'll, do your pregnancy thing and then get back on it. And it's really just shocking to me.
We'll talk about that. We should, I mean, obviously we'll talk about that another time.
I was going to say, we have to have another,
we'll have to
have you
that.
on like 3 or 4 times to just cover all of these topics.
Because the pill is, just like one short sentence, the pill is not a cure for either HA, especially HA or PCOS. I mean, it's arguably more helpful sometimes for PCOS, but for HA, actually the research is it in the long term makes it worse, probably for various reasons. But
yeah, and I'm sure you know also that in female athlete triad with women with osteoporosis, that the hormones that you get from birth control don't actually build back up bone. So they're telling women, oh, you have osteoporosis or low bone density, you need to go on birth control to fix it, and it doesn't even actually work.
Yeah.
So
absolutely.
Another podcast for another time, but
another day. Yeah.
But like you said, PCOS is reversible. It's at least manageable, if not reversible. And we can get to a place, those of us who have that tendency or have had a full-blown diagnosis and have very severe symptoms, we can take steps to deal with it appropriately. And one thing I wanted to make sure we talked about, since I know we're getting towards the end of our time, you have done a great job of explaining the different functional subtypes of PCOS, which I strongly believe affect how a woman should approach the actual treatment, whether that's diet, lifestyle, supplements, all the different things you can do for PCOS. Understanding what subtype you have will drastically impact how you proceed to resolve it. So can you talk really quick, like just high level, what are those 4? I think you said 4, right? 4 different functional subtypes.
Yeah. And these are what I've just broken it down into based on clinical observations. So it's actually a bit quite different than the phenotypes that are kind of more officially described, which are really just to do with whether you have polycystic ovaries or not.
That's kind of like lean versus.
Yeah. So this is more like so basically it comes down to a simple understanding, which is that PCOS is not one disease. It's not a disease, first of all. It's just a functional hormonal state, really, description of a hormonal state. At the moment, the condition is just a description of symptoms. And you can have arrived there at high androgens for different reasons, several different reasons. And so that's why, like from a treatment perspective, especially from a nutritional or functional treatment perspective, obviously we have to go upstream from the androgens and think for this individual woman, what is driving that? And that's just how I get better results. I think it just makes a lot more sense. So the main driver, I talk about it as drivers in my book, I think, drivers of androgen state or insulin resistance is the big one. It's the big one in terms of it's probably of the women who are properly diagnosed with PCOS and not mistakenly, told it when they have HA, but like of women who actually have PCOS, probably I think 70 to 80% of the time, insulin resistance is the main underlying driver. That doesn't mean it's the cause per se, because the cause is definitely going to be more genetically kind of how you're calibrated, maybe some degree of exposure to toxins, probably in utero, like all kinds of things like that set you up for this vulnerability. And the interesting thing is the high androgen state also drives insulin resistance. So it becomes a little bit of a circle. So it's not like you brought this on yourself by just eating badly. Like that's kind of what I want to talk about. Like you've ended up in this state of high androgens and insulin resistance. And the way to reverse out of that is to treat the insulin resistance as the primary thing that you're doing. So, and that involves diet to some degree, like not necessarily just a keto diet across the board, but like all various types of ways of doing that, depending on your situation. The supplement inositol, I really want to mention it because it's so good. I feel like I'm doing an infomercial for inositol. It's that good. Like it's cheap, which I like. Any brand is fine. It's an intracellular signaling molecule. So it improves the signaling of FSH and probably insulin as well. So it improves insulin sensitivity, improves FSH. So you get more of this normal progression to ovulation. Keeping in mind that as soon as, again, I said this earlier, but as soon as you can start to ovulate, then the hormones you're making, estrogen and progesterone, also help with the insulin resistance and the androgens and the whole picture. So it becomes a feed-forward beneficial cycle. So, and then the other subtypes, I guess, so we've got insulin-resistant PCOS, And again, not just assuming it, but actually being tested for insulin. Hopefully your doctor will do that. In some parts of the world, like where I am, people can just self-order tests. I know it's probably not like that in the States, but.
Actually you can.
Yeah.
But I think you have to have the appropriate, recommendations, but you can order your own tests in most of the United States.
My favorite would be, and you can love to hear your thoughts, but a glucose tolerance test with insulin. So that's the test where you drink a sweet drink. They take a fasting test, then you drink a sweet drink, and then they take a 1 hour and a 2 hour test. And they often do that measuring glucose at all of those points in time, but you can do it with insulin. And to me, that's the most useful. That's the gold standard. Yeah. Yeah. And it's annoying to have to drink a glucose drink, but it's patients don't love having to do that, but it's one time. I just don't see that any harm is really going to come from that glucose. So okay. So then the other types I put them into is post-pill, which is different in that it's really usually a temporary state trying to come off drospirenone, specifically Yasmin or Yaz, can create this temporary high androgen state. That's pretty common. I'm sure you've seen it. And it can take a couple of years to resolve. And during those couple of years of rebound high androgens, you can qualify for a PCOS diagnosis. It doesn't mean you will always have that. So my question for PCOS is, what were your periods like? What was your situation like before you ever took this pill? If there were some years before the pill, if they didn't go on the pill at 13, which makes it hard, but if there were, and on that topic, I do have to say, with my patients, one of my big questions for them when I'm trying to determine how this is going to go and what they can expect, my first question is, did you manage to have any years of cycling before you went on the pill? Because that maturation process of have those early years of periods is really important for, big picture, what that's going to look like. It doesn't mean if you were unlucky enough to go on the pill at 13 and have been on it till 35 and you come off, I'm not saying you will be able to go on to ovulate eventually and have normal cycles, but we just in a clinical setting, we don't quite know what that's going to look like because you've never had periods before, right? So we're I don't know what that's going to be like. So that's the whole post-pill conversation. Then I also classified the one I'll mention next, which is not the order I do it in the book, but adrenal PCOS is really quite different. It's quite rare. It's only about 10% of women, but they could still be ovulating. Actually, the ovulation could be fine. They don't have insulin resistance, but they're just pumping out a lot of androgens, mainly from the adrenal glands. Strong genetic component to that. I think there's some evidence of, again, toxic exposure in utero. Some evidence, which is kind of intriguing, of severe stress around the time of puberty for some girls can kind of ramp that up. So the treatment is different. Then it's not that easy to treat, actually, that kind of androgen excess, but there's some things you can do. And then the fourth category I did was more the inflammatory type of some of the, if you really do have something going on with your gut or gluten, for example, or something. By inflammatory, I mean immune disrupting, you've got other maybe autoimmune signs like psoriasis or something like that. Then for those women, addressing that underlying immune type of inflammation is a way to make the ovaries happy and get them to ovulate. Mm-hmm.
And I wonder if that inflammation is also coming back to the insulin sensitivity piece, where inflammation affects insulin sensitivity. So even if you're not overproducing insulin, you might just not have that insulin signaling working the way it needs to with the ovaries.
It could be that insulin could be involved. So they're not mutually exclusive, right? So so you could have insulin resistance, and insulin resistance, is associated with inflammation. But I guess I would see that type of metabolic inflammation a bit differently, big picture, than people who have something really going on with gluten or dairy, which is actually not that common. I mean, I know we talk a lot about avoiding these inflammatory foods, but they're not that. Those, for example, wheat is not inflammatory for everyone. I'm not in that camp that thinks that. I think there are certainly some people for whom, gluten is the example, for whom it's causing quite a profound type of inflammation in the body, and then that needs to be addressed. So.
Yeah. Well, and like you said, I mean, any source of inflammation in the body, no matter what that is, if it's a gut infection, if it's an autoimmune disease going on, there's so many different reasons why that might be happening. Circadian rhythm dysregulation, all of the things that can drive that need to be looked at. But just to recap for people, so we have the more classic insulin resistance PCOS, we have post-pill high androgens that can be diagnosed as PCOS. We have adrenal PCOS, which is really more from adrenal overproduction of androgens. And then we have the inflammatory PCOS, which can create a similar type of presentation, but is really more due to the inflammation process happening.
Yeah, I think that would be a reasonable summary. And there's probably other functional things going on that, but those are the big four that I see.
Yeah. And I mean, I think at the end of the day, it's all going to play together, right? Like you can't necessarily separate it 100%. Not many people with insulin resistance also don't have some inflammation going on. And so many women who had been diagnosed with PCOS were put on the pill to quote unquote fix it. And then now they're dealing with post-pill exacerbation. So it's rare to just have a very clear, this is the thing that you have and you don't have anything else going on. But I think it's good to just have all those different angles to say, what is driving this and what do we need to do to deal with it? And then you can really use different treatments or lifestyle changes that can help with all of those areas. And that's the other thing is a lot of times the best approach to PCOS is still going to improve insulin sensitivity. It's going to reduce inflammation. It's going to help you, detox from any sort of birth control, hormones, that kind of thing. So the good news for people that are either practitioners or women that have PCOS, it's not that there is like this complete black and white, you have to have the exact diagnosis to make the right decisions.
No, in fact, a conversation I'd often have with my patients, if I might even say something like, okay, yes, you could be under the PCOS diagnostic umbrella, but at the end of the day, does it matter? Because we also know that you have zinc deficiency and you're reacting to dairy and so let's work with what we know for sure, and then see what your periods do, and then see if and that's what I talk about in my book, the periods being the monthly report card, and that takes a few months. But let's make these changes, these act on things that we can see very clearly, and then see where you're at in 6 months in terms of that PCOS diagnosis. And it depends, that's obviously depending on the severity of symptoms. Women, at the end of the day, what a lot of women are most concerned about actually with PCOS is skin. So if it's worth it, if it helps at all, you can treat acne without definitively knowing if you have PCOS or not. You can just come in with zinc, I would argue, dairy-free, probably in many cases for acne, or whatever the acne treatments are, you can treat that and get symptom relief without having to exactly know your diagnosis, especially if it's a post-pill situation.
Mm-hmm. Very true. Well, I want to respect your time because I know that we are limited today, but I think this is a great example of why we were able to hang out for multiple days when I saw you and just talk about this stuff, because there's so much interesting things to talk about. And like I said, I will definitely have Lara back on because we need to talk about birth control. We need to talk about menopause. There's so many things we need to talk about. One question that I ask every single person that comes on this podcast, and I wanted to make sure I didn't miss it for you, is what do you believe makes a woman more than a body?
By body, I know kind of what you're asking. I certainly don't think, our body image has anything to do with us being a woman, but our hormones themselves and their benefits. So I guess I might say, the beneficial hormones are what makes us a woman in a way, from a biological perspective. And that was one of the questions we didn't get to today, actually, is all the many benefits of ovulation and all the ways that helps our brain. And
that'll be part 4.
That'll be part 4. But yeah, our hormones are a superpower. And that is true. You just having, just being a woman, it doesn't matter if you're what you look like or even if you have perfect periods. It's the other thing too. Even though I value hormones and periods so much, I also want to step back from it's okay to have imperfect periods for some part of your life, or that doesn't take away from being a woman.
Awesome. Well, Lara, it's been such a pleasure to chat with you as always. I have a feeling that we're going to have a lot of people that want to connect with you further or read your book or all the above. So where can people find you on the internet?
I am easy to find. So everything is Lara Briden. Lara, not Laura. So we're kind of twins and almost having the same name, but not quite. So I'm at larabriden.com. All my social media, which I guess really just all I do is Instagram, Twitter, and Facebook, is at Lara Briden. My book is Period Repair Manual.
Awesome. Well, we will link to all of that in the show notes so everybody can find it. And then, like I said, I'll definitely have you on for future conversations because I just love chatting with you in general. And you have so much wisdom to share. And I know that everyone's going to benefit from hearing you talk about these various topics. So anyway, thank you again, Lara, for your time. And thank you to all of you listening. Thanks for spending this hour with us. And we will see you here next week on the Fed and Fearless podcast. Take care, everyone. Hey there, Lara Schoenfeld here again. Are you a dietitian or nutrition entrepreneur who wants to start or grow an online business? Are you feeling stuck, frustrated, or even downright scared when you think about taking the next step towards your dreams of entrepreneurship? Trust me when I say that I've been there before. I've been running my own online business since 2014, and I worked with Chris Kresser to help him grow his business starting in 2012. And over the past 8+ years, I've learned a lot and made a lot of mistakes when it came to creating the multiple six-figure business I now run today. And if there's one thing I've learned since starting my business, it's this. You don't have to figure out how to transform your knowledge, expertise, and passion into profitable online courses, digital products, and memberships on your own. I've personally invested over $100,000 in my own business education, mentorship, and coaching. And I can honestly say that I have no idea where my business would be today had I not taken the leap to invest in myself and in my success. I might not be running a business where I get to work with amazing clients every day, helping them solve their biggest health and business challenges so they can live the purpose-driven life they were put on this earth for. Remember, becoming an in-demand expert in your business isn't about being egotistical or selfish. It's about having a deep commitment and a burning desire to help others. And if you're not growing your business successfully, there are hundreds and maybe even thousands of people out there who are missing out on the opportunity to get the amazing help and support that you were born to provide. You're here for a purpose, and if helping people improve their health by running an online business is one of your purposes, then I have an exciting opportunity that'll help you build your business even faster and easier than ever before. My world-class business coach, James Wedmore, is releasing an awesome video series for entrepreneurs called The Rise of the Digital CEO. In this series, James shows you exactly what keeps most business owners stuck and struggling and reveals the 5 areas you need to focus on to overcome whatever is standing in the way of your success. Now, if you don't know James Wedmore, he's a self-proclaimed serial entrepreneur who's built multiple 7-figure businesses in multiple niches. He's also one of my favorite coaches and mentors, and he's helped me completely transform my mindset around business so I could grow my income and impact while also working less and enjoying life more. The financial and time freedom I've experienced has been life-changing, and I want you to have that experience in your business as well. This is your chance to tap into a series of instructional videos that'll show you exactly what you need to blast through whatever's got you stuck and give you the power and confidence to take on the world of online business. And best of all, this video series is totally free. So if you're ready to start taking charge of your business and your life, go to fedandfearless.com/rise to watch these videos before they go away. While you're there, you can also get on the waitlist to learn more about James's amazing online program, Business by Design, which helps struggling service-based coaches and course creators transform their businesses from the inside out so that they can experience the time and financial freedom they desire while having a bigger impact on the world. And if you decide to join BBD under me using one of my links, you'll also receive bonus coaching from me. You'll learn additional tools and strategies that are specific to nutrition and dietitian entrepreneurs who want to start, grow, or scale their business to 6 figures and beyond. I'll be teaching you things like effective sales call strategies, how to stand out online in a crowded market, and how to develop your first or next online nutrition program, and more. If you want to learn more and watch James' free video series, The Rise of the Digital CEO, go to fedandfearless.com/rise. This video series is only available until Thursday, June 25th. So don't miss your chance to learn the business strategies that have changed my life and the lives of thousands of online entrepreneurs. And feel free to DM me on Instagram if you want to find out more about my bonus business coaching opportunities for anyone who joins Business by Design under me. It's time to rise in your online business, and I can't wait to support you on your journey to becoming the confident digital CEO you desire to be.